Okay. All right. So today for FND Awareness Day, we've got Dr. LaGrand here to talk to us about his fellowship in FND. Dr. LaGrand is a neurologist that has a specific interest in FND. I'm just going to make you host. Okay. Over to you.
All right. Then I share my screen. And I hope, Kate, can you see the presentation right now?
I can briefly. Yep, thanks.
Awesome. Well, let's start it. My name is Dr LaGrand, and I'm a Dutch neurologist who is currently doing a fellowship in movement disorders and specifically functional neurological disorders here in Brisbane, in Australia. Well, let me first thank the organization of FND Australia for inviting me for have a talk with you about FND and about my fellowship here in Australia.
Yeah, we're interested to hear.
So yeah, thanks for having me. First, maybe I have to explain a couple of things. My name is also always a big subject. My Dutch name is Tjerk, but as you can see, you spell it T-Jerk. My parents weren't native speakers, neither am I, as you can see. But yeah, after half an hour, the guys here in Brisbane said, man, that name of you have to come up with something else. So they let me choose between T-Bone or T-Dog. And then, well, finally, we ended up with TJ.
TJ,
so please, from now on, call me TJ. I call this presentation the Fellowship of FND. I know the Lord of the Rings and Fellowship of the Ring was actually done in New Zealand. I'm totally aware of that, but I thought, well, let's give it some catchy title. And let me talk you a little bit through the basics of FND and also about some specific research projects that we're doing here in Brisbane and that I did over the last year to get people excited about FND. First of all, I'm going to talk with you specifically about FND, functional neurological disorders, but I think functional disorders are actually much broader than that. And I think, we see patients, for example, with functional movement disorders in the neurology clinic, or dissociative attacks, which can look like epileptic seizures, for example. But I think that actually every specialty has its functional symptoms, and FND can be much broader than only neurological symptoms. So it's good to have that in mind when you examine those patients, that also other symptoms can be maybe very well explained by a functional abnormality. I always call it functional neurological disorders, and I know there are a lot of different names going around, but well, I think, and I learned that here in Australia as well, language is very important. And for me, the term functional neurological disorder, that's exactly what it is. It's not a structural abnormality in those brains, but there's a functional problem in the function of the brain and the nervous system. And I think that's also very important to tell our patients. And that starts with neurologists. If we keep calling those symptoms different or give them different labels, that doesn't help. And some of those labels are actually, well, pretty offending. I think hysteria, well, that's actually a very old term, still used, by the way. We sometimes still get referrals for people with hysterical weakness here in Brisbane as well. But hysteria, maybe you are aware of that actually comes from the Greek word for uterus, and it was called hysteria because Actually, back then, people thought it's only a problem in women, and they actually did hysterectomies in those women that back then, and they thought, well, when we remove the uterus, then all your symptoms go away. Well, luckily nowadays we don't have that in our treatment toolbox anymore. But it's also, I think, important that we also don't call those disorders hysteria anymore. Also, other terms, I don't like them. For example, if we see a patient and we say, well, you have a non-organic neurological disease, some of those patients can think, well, all right, now you told me what I'm not having, but what do I have? So I think that term is not very helpful. If we say to a patient that they suffer from pseudo seizures, they can actually, well, walk out and think, well, they call it pseudo seizures. So you actually think that I'm faking it, because pseudo is. And also another term I don't like is medically unexplained. So if a patient walks out and he just heard that he had a medically unexplained disorder, he probably think like, oh, that guy really didn't know what's going on with me. I really like the term functional neurological disorders because it covers what it is. And here in Brisbane, we also make a big point of that. And not only we use the term, but we also, our physiotherapists where we're working with, or our psychologists, they all call it functional neurological disorders. That's important. And it's not only me making this up, this language issue. It's actually a beautiful study done already almost 20 years ago in Scotland, where they actually asked patients in a waiting room, like, if you would have weakness on one side of your body and you see a doctor and he is telling you, well, that you use one of these terms that you see in the bottom of the screen, so medically unexplained or stress related, or what do you think that your doctor is telling you? Do you think that you're putting it on? Do you think that he's actually saying that you're mad, that you're imagining symptoms? And then they did something really cool. They calculated the number needed to offend. Well, in a lot of medical studies that we do, we have a number needed to treat, and we use that to give some numbers to, like, how many patients do you have to treat with a specific type of medication, for example, before you see an effect in those patients. And actually what they did in this study is they calculated the number needed to offend. It's a little bit different. They actually calculated the number, like, how many people do I have to tell, if I actually have to deliver with a certain diagnosis before they're feeling pissed off with me. And the number for those terms as psychosomatic or all in the mind or hysterical, that number is actually 1. Functional neurological disorder or functional disorder is also a very well accepted term by patients, because if we call it functional, you can also explain it to patients and they also can understand what they are going through. Then let's tell me something about some myths that's still going on in functional neurological disorders. And I don't know if you know the show Mythbusters. It's actually already a couple of years ago that I watched it quite a lot. But there's still some myths going on in FND. For example, all patients with functional disorders have psychological problems or recent stress. That's not true. Yes, psychological problems can be an issue in people with FND, but hey, also a lot of people with FND don't suffer from depression or anxiety, and they don't have any psychological problem or stress. Also very important, I think, that depression and anxiety is not only common in FND, but also in a lot of other neurological disorders. For example, Parkinson. Many patients with Parkinson also suffer from psychological problems as well. It's not only a motor disease, it's also a non-motor disease. So that doesn't differentiate between functional or non-functional disorders. Other myth about FND, FND is uncommon. No, it isn't. It's actually the second most common diagnosis that we have in the neurology outpatient clinic after headache. Actually, I did a study when I was working in the Netherlands. I worked in Groningen, and I worked in the movement disorder clinic. And for that study, we also looked at, well, actually, how many of our referrals for a newly referred patient with a movement disorder actually suffer from FND. Then that was a third. So of the 900 patients that we saw in 3 years' time, more than 300 suffered from FND. So no, it's actually very common. It's one of the most common things that we see in the clinic. People with functional disorder just need psychotherapy. Well, I explained to you already that I think, I already explained to you, well, a lot of people actually don't have psychological problems. So maybe they don't need psychotherapy, but maybe they use another sort of therapy. And I come back to that later. Also myth, patients have either a neurological disorder or a functional disorder. No, also not true. FND doesn't prevent you from getting another disease, for example, and vice versa. So when a patient with FND comes to you with a new complaint, you have to assess them again properly. Just what you would do with every patient that you see in clinic. Also interesting, there's also some data about it. Actually, 20% of the people with FND also suffer from a non-functional neurological disorder. For example, multiple sclerosis and FND, or Parkinsons FND and FND. So yeah, you have to assess those patients properly, and FND might or might not cover everything that the patient is suffering from. So these are all myths, and I hope I explained to you that these are busted now. FND is bizarre. There's still some some neurologists who think, well, if it sounds bizarre, it must be FND. But actually, there are a lot of things that we see in clinic which are pretty bizarre, but are not FND. This is, for example, a lady that I saw in Groningen in the Netherlands, and I will start this video. And she told me that she couldn't walk. She couldn't walk towards me. And I said, but that's strange because, well, you came actually to this outpatient clinic and I didn't see a wheelchair. How do you walk then? And she said, well, I can't walk towards you, but I have sort of walk sideways, as you can see. And when she walked sideways, she could make a lot of steps. And when she said, well, when I lift my knees very high, then I can walk towards you. Well, that sounds pretty bizarre, actually, if you have a patient telling you this story. And I think many people can think, well, that lady is, this might be a functional neurological disorder, or maybe she's faking it. No, she's not. This was her PET scan. And, well, I have to explain you have to see two very bright commas, as you see in the middle pictures, and her on the left side weren't that bright. This lady is actually suffering from Parkinson's disease. And she suffered from a symptom that we call freezing of gait, so that her feet are sticking to the ground. And she needed certain cues to initiate moving. And that knee lifting that you saw, or that sidestepping, were actually motor cues for her to initiate moving. So no, FND is not bizarre. There are a lot of things that are bizarre that we see in a neurological clinic. Neurologists don't like it. Well, I love Australia. I already told Kate a little bit about this. There's also one thing I don't love, that you feed your children with this stuff. It's called Vegemite. I think all of you know this.
Yep.
I hate it. Alex, which is my supervisor here in Brisbane, you see him left in this picture. He has a sort of tradition that after every surgery that we do in patients, we have to eat a sandwich with Vegemite. And well, I'm not enjoying those moments, I can assure you that. But to continue about FND, neurologists don't like it. And for me, well, I have a keen interest in FND. It's actually pretty hard to tell you this, but this is actually true. Neurologists don't like it. This is actually a study done 10 years ago, where they asked, it was actually a survey among neurologists, like, what kinds of neurological problems do you, well, like to treat? And you can see the likability on the left side. So what we like is Parkinson's disease. What we like is patients with carpal tunnel syndrome. As you can see, and I'm sorry to tell you this on FND Awareness Day, but maybe that's also just the reason that we have an FND Awareness Day. Neurology, functional disorders were actually, well, the least appreciated by neurologists. So there's still a lot of work to do, but hopefully we can do that today a little bit.
Yeah.
And yeah, sadly, because maybe some people say, well, this was actually a study from Scotland or the United Kingdom, actually. Also in Australia, if we this is a study that Alex did 2 years ago. Also in Australia, actually, if you ask people involved in FND, so not only neurologists, but also psychiatrists, nurses, GPs, physiotherapists, psychologists, neurologists are actually the worst. They actually are least interested in FND. So that's specifically the group where there's still work to do, because I think there are a lot of keen physiotherapists, there are a lot of keen psychologists who really like to work with those patients and have a lot of interest in it. And we also see that in the research projects that we do. The problem lies with the neurologists. Unfortunate, as a neurologist, I think I can say that. So actually that neurologists don't like it, this myth is actually confirmed in studies. How do we diagnose FND? I'm sorry, Kate, I'm closing this. How do we diagnose FND? There are actually two things where we always look for in clinic. That is inconsistency, and that also means internal inconsistency. For example, a tremor that's there at a moment and another moment it's not. And incongruity with recognized neurological disease. Neurologists are actually always looking for patterns in patients. So if we have a patient who is referred for Parkinson's disease, we look for, well, things that fit our pattern of Parkinson's disease. For example, that freezing of gait that I showed you, that's very typical for Parkinson's disease, or a resting tremor, also a typical thing in Parkinson's disease. Incongruity with recognized neurological disease is therefore also a little bit difficult, because, well, you have to know your neuroanatomy to say that it is not a non-functional or a non-functional neurological disease. Very important, and that's a big point I want to make today, is it's not a diagnosis of exclusion. So we don't tell our patients, well, we don't see anything on your MRI scan, so you're having a functional neurological disorder. That's not the way of doing it. We specifically look for what we call positive signs of positive features in FND, and I will show you a couple of them. But those are signs, well, as I told you about the freezing of gait, which is typical for Parkinson's disease, there are also a lot of signs that are very typical for people with FND. And we specifically look for those things during our neurological examination. For example, Hoover sign. This is a patient who suffers from leg weakness in his left leg. And Alex, my colleague, is actually showing that, that with a specific maneuver, actually there is still strength in the leg, only the patient can't get actually there. He's showing you this. The right leg is perfect. He asked the patient to lift it.
Push this one down hard as you can. Push hard. Good strength there. And now push this one up again. That's clearly weak there. Good. And push this one down again there. So clearly weak there. I can quite easily overcome. Good. And again, push this one up as fast as you can do. Hard, 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 hard. And now you can see I get normal strength back again on the left hand side. Yeah. Okay. Thank you.
Yeah. So what you see is that left leg, there is weakness in that left leg, but when the patient is lifting his right leg, actually you see that there is still strength in that left leg. And we should use these signs not to say, well, aha, now I've got you or something, because that's not what it is, functional neurological disorder. But you have to show the patient actually what is actually happening, when he's doing that maneuver. And that can help to also to show that to the physiotherapist, like this is something you can work on and use that in treatment as well. Another sign, this is a patient with a tremor, for example, a functional tremor. And I show you this video. You see, well, he's obviously shaking. But now what we do is that when we ask the patient to tap with a specific frequency, you see that also the tremor arms actually shakes in the same frequency as that right
Een
one.
ogenblik, dat kan ik helaas niet doen. Je kunt wat doen in de app contacten.
I'm sorry, Kate, that's still because my computer is probably Dutch, and sometimes I say with my accent probably a thing in Dutch, and then it's my Siri response. This, what we ask the patient now, is called ballistic movements. So he's following the finger, and let me show you that again. He's following the patient, and look at the left hand tremor. It stops and then it's back again. It stops and then it's back again. And well, I will tell you in a moment what I think what functional neurological disorders actually are, and how we actually explain those things that we see during our examination to our patients. Some of those signs that are described in FND, I actually don't like, because I think they are more used by neurologists. Actually, what I just told you, like showboating, like, hey, this is impossible to do with a non-functional disorder, so this must be FND. And this is not the way how we should explain those things. This is, maybe you know the game from your younger days. It's called the whack-a-mole sign, from the whack-a-mole game. And I'm showing you this because we actually did a study in these patients. This is a patient with, well, abnormal involuntary movements in her right arm. And when you suppress her right arm, the tremor actually moves to another body part, in this case to her left arm, and also a little bit more to her right leg. It's called the whack-a-mole sign. And in the literature, this is also a sign that might be useful in diagnosing FND. We actually don't think it's very useful, because a lot of patients with tremors, for example, Parkinson's tremors or essential tremors, when you suppress a specific limb or put the patient under pressure, that tremor also moves to other body parts. So maybe not very helpful. And I think this sign is actually more used by neurologists to trick their patients, instead of that is a very functional sign in explaining the diagnosis and in treatment. Another sign that we tested that is described in the literature is called the Swivel chair test. It's actually for patients with functional gait disorders, so problems with walking. And what you see is when patients are walking, they walk very hesitant and they have a lot of problems with it. But when they have to propel themselves in a swivel chair, you see that the gait actually improves. All right. Right, you can start. And we did this study in 60 patients with functional gait disorders. We still have to look at the, so this is her walking. And now I'm showing her in the swivel chair. And you see that in that swivel chair, she goes a lot faster. Okay. But this patient, well, I can assure you, she doesn't want to walk in a swivel chair. She just wants to walk better. So I think not a very helpful sign. And also maybe a sign that is also positive in a lot of other gait disorders that we see in clinic. For example, people with dystonia. So this is one of the research projects I did this year to look for a couple of those, well, positive signs, and if they are really positive for FND, and hopefully we can publish something later this year. So how do we make the diagnosis? Well, I told you we look for positive physical signs. We don't make the diagnosis on the basis of a normal scan, for example, or bizarre symptoms, weird symptoms. And you have to be transparent with patients. We're not tricking them. We're actually looking like, hey, is this FND? Because then we can also start the proper treatment for FND. So then what goes wrong in functional neurological disorders? And Alex and I here in Brisbane, we often, use the analogy of a computer. Some people like that, some people don't. And then we have to, go a little bit deeper maybe. But both these computers are not working, as you can see on my slide. I think everybody can see why the computer on the right side isn't working. There's a structural abnormality in this computer, and so actually the cable work, or actually the whole computer is broken. But hey, this is my computer here in PA Hospital in Brisbane, and I tried to start 20 different programs at the same time, and you can see that computer is also not working. But it's not a hardware problem, it's a software problem. And software, what we actually mean with software problems is communication. And that's not only communication with the outside world, but also communication within your brain and with your brain to your body. And in those communication routes, there it goes wrong with people with FND. And there are a lot of different reasons for that. And then I talk with them a little bit about what we call a biopsychosocial framework. That's a mouthful, I'm aware of that. And as I told you, yes, there can be psychological factors that can be of any importance for developing FND, but there are also a lot of biological reasons why people can develop FND, and social reasons why people can develop FND. And then we talk a little bit about, what we call predisposing vulnerabilities, like things that people, I think actually FND, it builds up. You don't just get it out of the blue, but it's actually building up already in your system. Your system is getting overloaded. And at a sudden moment, you have a precipitating mechanism or a trigger. And that can be a very minor trigger, a minor injury, for example, and that triggers off a functional neurological disorder. And then there are perpetuating factors. Actually, because you can say, if you can trigger it off, or if you can trigger it, why can't you switch it off? But that's not always that easy. And there are factors which actually play a role when people have FND, which actually keep them having those problems. And to tell you a little bit about another research project that we do, and I can't give you any results of this because this study is currently still running, and it's actually an international study. I started with this study in the Netherlands, and there we do it now in 5 different clinics, and also here in Brisbane now in 2 different clinics. And what we do, that what we saw when I worked in the movement disorder clinic, that we're still getting a lot of referrals for people with FND. And I already told you the number, like a third of the new patients that we see actually are suffering from FND. And I think that is same practice here in Australia. There aren't very many neurologists which are keen in seeing those patients, so they have to wait. And also here in Australia, I'm sorry to tell you this, but the waiting list is more than a year now to see me or Alex if you suffer from FND. And we thought, well, can't we make people a little bit more alert, like, hey, what type of patients develop FND? And that's not only what I told. It's not like if you suffer from psychological patient problems alone, but also for those biological factors and social factors. And what we're doing is actually that we are working on a prediction thing to make GPs or physiotherapists or other doctors or other neurologists more alert, like, hey, if I have this patient and he's telling this, and this, what is the chance of actually that this patient is suffering from FND? And then ask them to maybe look more specifically on those positive signs during their examination, instead of like, oh, I don't know, I know some guys in Brisbane which have that FND passion, so I refer them back to them. No, maybe already start with some form of treatment. And I don't want to turn them all over into FND experts or something like that. But I think a third of all the new referrals, that's really a lot of patients. And I think there are a lot of patients that actually can be already treated earlier. So yeah, that's what we're working on. Another research project. Treatment. So if we see a new patient in clinic, it's still. Sorry, Kate. If we actually, I think with making the diagnosis, you actually already start treatment, and delivering the diagnosis properly to the patients, and that they also really understand what's going on. That's actually a first very essential step in treatment. So when I see a patient and when I find positive signs during my examination, as you saw with Alex in the video before, we actually also already mentioning that to the patient, like, hey, do you see what happens with your tremor over there? Or do you see what happens with your weakness in your leg if we ask you to lift the other leg? And to explain a little bit more about what's going wrong in those software systems and what's going wrong in that automatic pilot, which is not working in those patients anymore. So I think essential treatment. And then I think every FND patient is different. And one of those myths that I told you before, like every patient needs psychological therapy, I told you that's a myth. It's not true. Some patients, well, you have to see what kind of patients do I have in front of me, and then look what are the essential things for this specific patient. For example, if the patient is suffering from chronic pain, as key feature, well, I think that you should refer them to a pain specialist and work on managing pain. Yes, if they suffer from psychological symptoms, of course, I refer them to a psychologist. But if they don't, I don't refer them to a psychologist. If they suffer from a functional movement disorder, I think a good physiotherapist, a sensible physiotherapist, hopefully also with some interest in FND, they work on improving those movements. So you have to see and actually also discuss that with your patient, like, hey, what are your specific symptoms and what do we think, well, is worthwhile working on, and what are the things where we maybe don't have to work on. So that's important. So it's not one size fits all. I think you have to have the discussion with every single patient again and again. And then I think also important when we explain them the diagnosis, and I'm not here to make publicity, but we have this website, FND Australia. We also mention that to our patients and to say like, hey, we have a lot of good materials on the website. We have some videos with some, well, good explanation about what is FND, how do we diagnose FND, what is the prognosis of FND, how do you treat FND. Very helpful. Those are all 2-minute videos, nothing fancy, but just to, well, actually already start treatment, because maybe the physiotherapist also has a waiting list, or with COVID, the psychologist doesn't see new patients, and you can already do a lot, even with offering your patient some material about FND. There are videos on the website, there are workbooks on the website, and a lot of information. And I think, well, why not mentioning it and see what the patient already can do or can start with. And I think this is one of the most awesome projects here in Australia. And I have to warn you, it's not published yet. I'm showing you now some preliminary data, but because we are so excited about this, because we all know FND, it's not a very fancy disease. There's not a lot of money going on in FND, and money talks, as it always does. So we wanted to show people what a good explanation can do in FND, but also what a bad explanation can do in people with FND. And many of our colleagues in PA Hospital doesn't know that we did this study, but what we did is we looked in 25 patients with dissociative attacks, also called pseudo non-epileptic seizures, but I already explained to you why I don't like the term pseudo. But if you think, well, it's still a term that still goes on in the FND world. But we asked 25 of those patients. Actually, we looked in our data, and we looked specifically to healthcare utilization 2 years before they got the diagnosis and the 2 years after they got the diagnosis. And we looked for number of ED presentations, number of hospital admissions and days of hospital admissions, number of outpatient reviews, mental health reviews, blood tests, imaging tests, and EEGs. So we looked to those things and we calculated the costs of those specific things. And then what we did is, well, what I said, we looked in what did we think is a good explanation of FND, and what do we think is a, well, acceptable diagnosis of FND. And I told you, I don't want everybody to become an FND expert, but we looked at 6 specific things. First of all, just mentioning the diagnosis, call a spade, call FND if it is, when it is FND, and don't tell your patient like, oh, the scan was normal, go home. We looked at, is there something of an explanation giving about the diagnosis in the letter or in the file? If they offer the patient some self-reading or online material about FND, if they refer them to a proper a therapist, and that could be a physiotherapist, by psychologist, psychiatrist, rehabilitation doctor, pain specialist, but a referral for somebody to work on treatment, a letter sent to the GP, and appropriate follow-up. And that is that you see those patients back at least in 6 months again. And if you score more than 2 points of these things listed here, we already said, well, we think that's an acceptable diagnosis. And what I told you, 2 points is just mentioning the diagnosis and send a letter to the GP. So not that much work for a doctor to do. And if they didn't score 2 points, so if they scored 1 or 0 points, which unfortunately that still does happen, also in the hospital where we work, We called it a bad explanation about FND. And then we calculated the cost 2 years prior, 2 years after. And I think this is actually mind-blowing. In green, you see the costs before a satisfactory or good explanation about FND, and after explanation of a good explanation about FND. And you could reduce the costs actually with a third, which is, and you see the Australian dollars below, that was that's already almost more than $100,000 in only 25 patients. But then we also looked at the people who, what we thought, received a bad explanation about FND, or an unsatisfactory, to keep it polite, about FND. And you see, if you don't do your work properly as a neurologist, which your job is actually explaining a diagnosis correctly to your patients, those costs actually increase with more than 150% in the next 2 years. And I think that if we get these data published, this is actually very helpful to show managers, to show boards in your hospital, to show what a good explanation and some just normal human interest in FND can do. And then, because then we always get the thing from reviewers, yeah, but you also have a lot of patients who suffer from both. They have epileptic attacks and dissociative attacks. And what do we have to do with those patients? And we did the same thing. We looked, well, and I have to warn you, this is only done in 6 patients with clearly both disorders, so both epileptic seizures and dissociative attacks. And we looked at the cost, and also in those patients, actually, you could, if you just tell them like, hey, not all your attacks are maybe epileptic in nature, but some of them are maybe dissociative, and we're not only giving you medication for your epileptic attacks, but also, well, give you some good information about FND and refer you for proper FND treatment in FND. And you see in these patients, you could reduce the costs with a good explanation about FND with 75%. And actually, if you don't do it properly in those patients, that is more than 700% the healthcare cost after a bad explanation in the next 2 years. Because those patients, yeah, and well, look for yourself, what if you don't get a proper explanation about your symptoms, you will keep having those symptoms because
and keep
you
looking
don't have treatment for it. So it makes totally sense. And I think this is a thing that we, well, as a FND community, hopefully already know, but now we also have some data and some money numbers to show that this is actually the thing. Mind-blowing, I think, but maybe I'm a little bit biased. That's totally true. Then prognosis in FND, and I think also, well, with a diagnosis you have to be honest, also with a prognosis you have to be honest. And what we always have is the rule of thirds, I think, because if you read in the neurology books about FND, always one of the first things you can read is like FND is reversible, and your symptoms can go away with proper treatment. Yes, that's true, but also keep in mind that's only true for a third of our patients. So what we, and as I told you, I think we, well, not to be cocky, but we're doing a good thing here with FND and FND treatment. If we look in our data about patients with FND, we see that a third of our patients actually, they can maybe go back even to work or to what we say is actually, well, reversible FND. But a third of the patients are actually, with proper treatment, they stay stable, which is still, I think, very worthwhile to work on, to just manage the symptoms in a stable way. So they keep having attacks, for example, they keep tremors or movement disorders, but you can, well, pretty much stabilize that. But also a third of the patients with FND actually has a poor outcome, and they actually worsen also after proper treatment. And that's also the honest story. And I think it's, you should have that discussion as well with your patient. And that doesn't mean that those patients that you don't have to start treatment for them, but yeah, this is just the natural course of the disease actually. What are poor predictors for outcome? And that's one of the reasons why I think that prediction study where we're working on is so important, that we diagnose things earlier. Chronicity. So if people come to our clinic and they tell us like that they suffer from dissociative attacks already for more than 20 years, well, in the Netherlands, I always learned, well, the long you have your symptoms, the long it can take, well, the minimum amount of time you have to work on it. So if a patient comes to me and says, well, I have the symptoms already for 20 years, I'm also being honest, sorry, but then it will probably cost you at least another 20 years before you see improvement. Key point actually, we should diagnose these things earlier and start treatment earlier for our patients.
Which is a problem if people are waiting 12 months to see a neurologist.
Exactly. But that's why, well, I think, well, in an ideal world, yes, a diagnosis should be delivered by a neurologist. But hopefully I showed you already a little bit that I think there's already a lot of work that can be done by GPs. And we often see patients that are referred to us and had to wait for more than a year sometimes. And they said, yeah, but I wanted to work on it, but the GP didn't offer me anything. And a physiotherapist. And I understand that a diagnosis can be key for a lot of treatment things, and we can have a discussion about it. But it doesn't mean that doctors can, well, maybe try a little bit better or try to explain at least something about what's going on in those people already. And what also, well, I didn't put that in my presentation, but what we also work on now is a recommendation guideline for FND, specifically also for the more rural parts of Queensland. It's a statewide recommendation, but I think it can be very well used in the rest of Australia as well. And we've also some tips and tricks for maybe people who work in a more rural area that say, well, we have those patients and we think, well, some of the symptoms might be very well explained by a functional neurological disease. We can give them some guidance already in an earlier stage. And then another last thing, but I think, I did a fellowship here, and for doctors who are doing fellowships, research is always a big thing. And this is one of, well, I think also awesome study that we did. We often get the question in clinic about driving and FND, and can I drive? How long shouldn't I drive, or how long do I have to be symptom free? And currently there are no guidelines at all in Australia about driving in FND. And at the moment, as smart as we sometimes maybe sound, actually what we do when we're sitting in clinic now is just, well, we look at the patient and we, well, just some common sense, like, hey, maybe in your case better not to drive, in your case not, but there's no data at all. So what we did is that we asked, actually this is a collaboration that we did with the guys from the University of Queensland, who are also involved in the, well, if you want to get your driver's license here in Australia, what do you do? And what you have to do now is what's called a hazard perception test. And what you see, I will start the video, is patients are actually sitting in front of a laptop, and this is actually a sort of simulation. They are driving this car, and if they see a potential traffic hazard, they have to click, for example, now on this bike, that I have to move a little bit to the right, and they look at how fast you respond to traffic hazards and how many different hazards that you see. That is one of the things that we tested in patients. The other thing was we asked them a questionnaire about driving behavior with questionnaires. How many crashes did you had in the past and after your diagnosis of a lot of questions about drive. And we did a hazard prediction test, and that is pretty similar to the test I showed you in the video. But now it's not that you have to click on the potential traffic hazards in real time, but the screen is cut to black, and actually you are questioning, well, what are the different things that you saw in the video? And you have all the time in the world then to respond like, hey, I saw a car coming out of the left street, and I saw some pedestrians crossing the road, and you can come up with as many things. And also, I have to warn you, preliminary data, not published yet, but I'm just keen to tell you this.
Do you see this leading to some guidelines being available?
Sorry?
Do you see this leading to some guidelines being available?
Hopefully this is, and well, I will tell you in a few seconds, there are a couple of more projects of this study that we now actually want to do, because interestingly, people with FND scored similar results on the hazard perception test. So when they had to click in real time on potential traffic hazards. So compared to healthy controls, similar results. So they weren't worse in driving. If you, interestingly, people with FND scored better on a hazard prediction test. And we think, well, so when the screen is cut to black and they had to say, well, what did you see in that video? They saw a lot more hazards than control. And what does that mean? Well, we're now still working on this data, but well, one of our hypotheses is actually that what we see that hypervigilance can be a key thing in people with FND. So they see a lot of potential hazards already, but they're also already adapting that in their brain. And maybe that's the reason why they scored better in the prediction test. And well, similar in the perception test. And what we want to do now, and this is future studies that we just now still brainstorming on, is actually look when you put them in real time in a car or in a simulator, and you look for eye movements, because maybe that have hypervigilance also causing them to screen, well, more of the total area than focused maybe to a specific thing, and that can cause maybe that sort of thing. So we're working on it. But interestingly, and also to maybe for neurologists who now, maybe some neurologists say, yeah, you have FND, and I think that's a scary disease, and I don't know what to do with driving. I think very interesting to show them now some data like, hey, actually compared to healthy controls, similar, and with prediction, actually better. So what does that mean, and what should that mean for guidelines? And we have to work on that in the future.
And it also depends on the type of
interesting study as well, I think. So to come to my conclusions, as I mentioned, and I mentioned it over and over again, and maybe you already get bored from me, a diagnosis, it should be based on positive clinical signs. I think it's bad practice if you just send those patients away without a diagnosis, without an explanation, without treatment, and only tell them that their MRI scan is normal. That doesn't cut it. And I think that explanation of the diagnosis, you should do that in a non-judgmental way. And treatment starts already when you first meet your patients. And as a doctor, you have to be aware of that as well. So hopefully get you a little bit more aware or excited about FND, I totally am. Alex always ended his presentations with this beautiful picture of Queensland. But to come back to the myths, I also, as you know, I'm always giving you the honest answer. For the last month here in Brisbane
and New South Wales,
wasn't like this.
Exactly.
It was actually more like this. This is a picture from our research room. But I had an awesome fellowship here in Australia. I'm really keen to work further on FND when I'm back in the Netherlands, unfortunately. But maybe, and I'm working on that, that I can convince my wife to come back soon. Because I loved it here and enjoyed my fellowship and all the FND patients. Yeah.
Excellent. Thank you. We look forward to seeing your papers being published.
Yeah. It's a work in progress, but
Awesome. All right. I've just got some questions from our members. You were talking about, the rule of thirds, 1/3 improve, 1/3, stay stable, 1/3 might, get progressively worse. With the improved, how much are getting completely recovered? Because a lot of people do improve with treatment, but they don't fully recover.
Yeah, a very good question. And what we often do is, I learned a lot from my patients actually, and also from a couple of my star patients who actually almost fully recovered to work, for example. And what those patients told me is that, and I think there's a lot of truth in that, is that I believe that once a brain learns to go on different pathways in that software system, that vulnerability will stay there.
And that's what we say.
And even those star patients who got back to work, for example, they tell me like, yes, I am back to work. I am now back to normal functioning life, but I'm not the same as I was before. And what those patients do very good is they recognize their specific triggers or underlying factors, and they are well aware of, hey, when this and this happens, maybe I have to take the day off,
need to rest,
or I have to cancel and got it there, because I think a lot of patients also recognize that when the build-up, when the brain is already in that red alert state, and you have the flare is actually there, you have to run it out. You can't stop it then. So you have to stop it earlier. But to come back to your question about that, vulnerability, I think once the brain ever learned to, go in a different direction than it should, that vulnerability will stay there, unfortunately. But
and that's what we do see. What about with age? So in terms of, children who are more the brain's more neuroplastic, younger people, 20-year-olds compared to 40-year-olds compared to 60-year-olds, do you notice a difference in terms of younger people potentially having better outcomes than older people?
Depends, but also very much depending on how long they have their symptoms already. Because even when I see a young lady with 70 years from 70 years old, for example, who tells me, I have these things already since I'm 10, that's already 7 years, and that's a long period. I also sometimes have patients, and I think one of my oldest patients, she was 86, and she had Parkinson's disease, but she developed also functional tremors on top of that. And because we saw her for her Parkinson's disease quite regularly, we say, hey, we saw already quite soon, I think after 6 months, like, hey, this and this, that's actually your Parkinson's disease, but this part is actually your FND. And I think, but again, maybe biased, because we were so early in that lady who was already 86 years old, actually she improved a lot from just a proper explanation and just a proper physiotherapist who worked on her tremors, her functional tremors. So I think, most younger people have better outcomes, but the key reason is that we are earlier there. Exactly.
And then so your earlier diagnosis leads to your potentially better outcomes.
Okay. But keep in mind that rule of thirds, and I'm also with young patients, I'm honest about that as well, and also questions about and I have to, I'm not aware of all the different things in Australia and all the different regulations that you have for NDIS, for example, or disability pension.
That's an area that I'm
also honest about that. And I think when we consider it after proper treatment as a permanent condition, I think also things as NDIS should be